podcast.
Okay, got it. So, okay, it's already silenced. That's good. Actually, let's go back. Now, Alyssa, I guess you have to start this.
I don't know. Amanda's still here.
Yeah, no,
Yeah.
Go ahead.
Hi, everyone. My name is Alyssa Haber with Essence of Pod, with Essence of Medicine Multidimensional Protocols. Today, I have with me Kate. You can introduce yourself.
I'm Mike.
And
Also PA.
And I'm Dr. Abbasi. I'm a neurosurgeon. Okay, folks, what qualifies to talk us about what we're going to talk about? Why are we qualified to talk about this?
Because we went to school for a while, studied it for a while,
Very hard, I would say.
interacted with lots of patients, and
we do this every day.
yeah,
This is what we do. It is like a mechanic that is qualified to talk about the steps you take to diagnose a bad engine, and then what we are not going to talk about how to fix it. We are just today, we're going to talk about the so-called inspired mind multidimensional algorithm to Alyssa, what do you understand what the purpose of that algorithm is actually?
Basically, it's a chart or like you said, an algorithm with the hopes of being able to take a patient and their symptoms, any tests that they've ran, and basically place them into a category on where they fall, strictly based on those numerical values.
Yeah, well, it can be numerical, but as well, it's just a, let's go to the definition of the algorithm. So, Kate, what do you understand if you talk about algorithm? What is an algorithm?
Something that you can use to prioritize certain symptoms or stages
Very
for the
good.
patient.
Well, it goes beyond the patient. An algorithm is a practically step-by-step process that makes a complex process easy to follow up. Now, I'm going to ask Mike about the question. You get a box of you get a chocolate if you know what the origin of the word algorithm.
that's interesting.
Yeah.
He's so good at these too.
Yeah, I don't know about that. I don't know if I'll get this one out.
But, there's a chocolate at the
Iran?
Okay, good. No.
Are you asking for the country?
No,
or the root
algorithm,
term?
where
He
does it
wants
come
to,
from?
yeah,
Where does it come from? Algorithm. But
Math.
algorithm and algebra, they both come from Arabic language, and practically, you want to go?
No,
No?
that sounds stumping me. It doesn't
Okay.
sound Latin.
No,
It doesn't
it is
sound-
the Latinized version of a name of a person.
Oh, wow.
Mm,
So-
now that makes sense.
Algebra comes from al-jabr, Arabic for force, or the thing, because in algebra, 2 times 3 is always 6. There is no other way. So the force of the reason says 2 times 3 is 6. So it's a force. It's a force to reckon with. You cannot do anything around it. That's come from Arabic. But there was this guy about 1,000 years ago. His actual name was Khwarazmi. He's a Persian guy, actually, believe it or not. This Persian guy used to live in a country, in a city called Tus, which then practically put the first version of algebra in, and then algebraic kind of processes. He was so close to solve the quadratic equations, which we call the practically 700 years later after him, Newton and the Leibniz in Germany came up with the solutions. So he was so close to it. And he came up with a process in the mathematics that you follow certain steps, something very difficult, you follow certain steps, and it always gets you to answer. And those steps that he initiated was attributed to him. His name was Al-Khwarazmi, and the Latinized version of that was Al-Khwarizmi, and then algorithmi, and then so the name algorithm come from the name of this Persian guy.
So
You're
is
welcome. Algebra is Arabic for the force. The article, and force, jabr. That is scheme algebra.
I'll accept my chocolate later.
Okay. Well, algorithm, though, is the name of a person. So certain of steps that make a complex situation manageable.
Makes
So-
it make sense.
Does it make sense for this situation? The
Yeah.
joke this is truly a joke, spine surgeon tell themselves. You come with one case, spine case, to 5 surgeon, you get 7 answers. And one of the sad thing in the spine is that it's so variable. The kind of, like, let's say something like grade 2 spondylolisthesis, right? You guys know what this is,
Mhm.
okay? You can go with do you think the grade 2 spondylolisthesis, even I go more specific, this is a lingo talk now, grade 2 mobile, even worse, spondylolisthesis. Do you think that diagnosis always end up with the same solution? I'm asking always that the answer is no.
No.
It should, but it is not.
Mhm.
What is the most predictive of what kind of treatment in the spine patient get? But the most predictive is the diagnosis, is the severity of the thing, of the symptoms, is it the color of their clothing, or is it the mood of the person, or is the person they see first?
The person I see first.
That is the sad story about the spine, that the person, somebody with a spine problem sees first, is the most predictive of the kind of spine care they get. You may have somebody with grade 2 spondylolisthesis get 2 years of physical therapy, and then a spinal cord stimulation device, or somebody with a scoliosis get a spinal cord stimulation device, and you may have somebody with just a black disc and a little back pain, they get a fusion right away. The person you meet first, being chiropractor, spine surgeon, interventionalist, and so on and so forth, predicts the most what kind of spine care you get, not actually what you need. It is like, there's another joke, is that the student is having a zoology exam. Maybe you have heard of that joke. Have you, Kate? No?
Yeah.
So he has a zoology exam. He knows that this examiner always asks about the worms, okay? And this person is a lazy person, doesn't learn everything. He learns only thing about the worm and the exam, but his knowledge is just the worm. That's it. Then the examiner asked him about elephants, and he started panicking, and then saying, the elephant have a big trunk that looked like a worm, and start saying everything about the worm. Okay, that is the history of spine. That our knowledge is limited to what we are good at, and that forces that knowledge on patient rather than patient situation forces us algebraic, algorithmic to what we are going to do for that patient. So our multidimensional algorithm are exactly are supposed to overcome these human biases that every provider has. And it's based on, I'm going to share it now. It's based on the combination of work of chiropractors, spine surgeon, interventionalists, anesthesiologists, physical therapists, and all those things. And we twice a year, we are revising it. So the next revision is due. But let's start with the top to bottom, okay? Let's start, a patient comes to that sphere represents actually our medical care as a totality. Now, is putting hand on the patient is outside of that box, okay? We're just going to talk about the things that we have a good understanding. What do I need to do? Oh, okay, then I have to share the same thing. Yeah, maybe you can turn it up, turn those things up so it gets that as well. So there are lots of things that are not here, like, there's some hematopoietic, some other non-traditional thing and so on, but some of them are here, like acupuncture and so on. They're included here. There are lots of other things are included, but we are mostly talking about the things that we have good evidence of their effectiveness. If they're not, if there's not a good peer-reviewed kind of evidence that this is effective is not going to be here. And it's not about developing a full picture about like what kind of surgery you do. It's about making sure that you don't miss anything that has long-lasting effect on patient's care. So let's just let's go back around again. Let's go this way. Mike, describe what you see and your understanding of what that is.
So I see the symptoms and tests and things like that at the top. So the patient comes, and if they have symptoms such as progressive deficits or incontinence, we call those red flag symptoms. That's at the top left.
Yeah.
And so that's, somebody has those two things right away. We start to think we need to get some imaging.
Let me go with the recent example. Patient come to you, and in the last few months or last few weeks is really hard for that patient. It's losing function, hard to function. And one of those things that patient is losing is weakness. What is the next step?
So I would want to get imaging right away and do a physical
It's
exam.
red.
Yep.
So do you send that patient for come back in 2 months?
No.
Do you just send the patient for just injections, or what is the next step you do for that patient?
The first thing would be, get on the phone with you, but also
Because it's red. You see that there? It's red, and the red is zone 0. Okay.
Yep.
So, but zone 0 by itself doesn't make patient to go to surgery. It has to correspond to one of the red on the other side. Now, what is your favorite exam on this patient? Comes for the last few months, things are getting worse, and one of the things that's getting worse is weakness.
Yeah, I'd probably want to get a myelogram
Or
an
MRI.
Yeah,
MRI, myelogram, they're equal. Why do we like myelogram more than MRI?
because of the resolution of specifically the spinal cord.
And you see the bone better in the, lots of bone, and especially if somebody had previous surgery where there's a metal. So Kate, it's your turn now. When you get an MRI and somebody with previous surgery, what do you see where the metal is? Do you see the metal in MRI? You do?
Yeah, not,
What do you see?
not as much artifact as a CT.
Actually, the artifact on the MRI with metal is much, much worse, especially if you have a ferromagnetic metal, you see just a big blob. Now, most of the time, thanks God for us, we use titanium, that the profile of the metal is much, much less. But you don't, what does, and actually we did a medical podcast about the medical physics of this imaging. That's very helpful for you guys to go look it up. What does CT, what do you think what CT measures? When you get a CAT scan, what does CT actually measures? We send X-rays, right? Kind of X-rays. And then what is it actually measuring?
The densities.
The density of the material
that
to
takes to
block
reflect back.
X-ray. Okay, that is what it measures. Denser material, more signal. What do you think what MRI measures?
MRI has to do more with like the charge of the molecules in
All molecules?
of the
It measures the specific protons. Get even more specific. It measures the protons of one atom.
Water.
Hydrogen.
Wow.
Which is, it get even more specific. You're on the right track.
Yeah.
It measures specifically the number of the protons, proton in the hydrogen who are bonds to oxygen. This is how specific it is. Do you want to know how it does it? Because those protons are in a certain quantum status that are excitable with a certain amount of energy. I can go on and tell you how it really works. But at the end of the day, it measures amount of the water in a region. How much water is in metal? 0. So metal is always black. More than that, because it's so dense and it reacts to the electromagnetic metal. That's why you don't put your metal stuff in your microwave. So that is why metal makes not only is black, but it makes surrounding of it black. Okay, so not good. So that's why we prefer myelogram, because a normal density of the CT is 256, 256. Even beautiful picture, the computer makes up the rest of it. It's not really, information is not there. It's just like one of those Photoshop on Instagram. She looks like a beautiful woman, and you look at her, she's a potato.
AI.
Yeah, well, that is what MRI does. So it invents data where it's not there. And that density is 256, 256 in a regular MRI. It's 512, 512 in CT. So by doubling the information density in one linear, in one direction, you have 4 times the density, and you don't have spatial kind of distortion and so on. So, but you get MRI or CT myelogram in this situation. MRI is probably faster because for the CT myelogram, you have to put some contrast in, and you have to have somebody literally doing that, a doctor or somebody. But here with the MRI, even though it takes longer, doesn't requires, you know, an interventionalist. So you get that thing. And what you see in the C4-5, this is our case. You see a huge amount of disc prolapse that covers the spinal canal. So you have your answer there. What is the next step? Red on the symptoms,
Surgery.
red on the tests, 0, zone 0.
Yeah.
Okay.
They're gonna come see you. Yeah.
Now, yeah, you come to the other room and get me. Not they don't come to see me, because why is it what Alice said? Now it's your turn. Why do you think that is a red zone? Why did we made it red? This symptoms, progressive deficit, and if you learn anything from this visit, just that one, I'm okay with that. Progressive deficit and incontinence or acute weakness on the symptom side, and an imaging that shows you biological corresponding findings there. Why is it important to put that patient on zone 0?
Because at this point, I guess time is of the essence in the symptoms that they're displaying. So the longer you wait, more likely that their outcomes are going to be
exactly
poor.
Exactly. You don't wait a month, you don't wait a week. You just start getting help for the patient right away. Now, let's dissect that a little. And there's some other slides here that explain that a little better in the next few slides. Now, if that patient has the symptoms within a day or 2, you send the patient to ER, because this is a medical emergency. But what if it's like 2 weeks or a month? Then you have a little more time. Because, you know, that if you don't deal with that within 8 to 24 hours, the chance that you're acute, you know, you get crazy and get active, overactive, if it's necessary. Because every time we get overactive, we have to miss steps, okay? Like, and the medical clearance doesn't really matter anymore, no? You go to OR, done. But is it always good to step those steps? No. But so if in the next few slides here, you see that, you know, you deal with them differently if it's just 8 to 24 hours rather than 2 to 4 weeks, okay? So then, but you adjust that. But from your side is that when you see them, you start, you know, channeling them in the zone 0 and zone 1. Now, let's put it in the, you know, that they have acute weakness now for 2 months, not for 2 days, and not bladder incontinence, and the weakness is like 4- is significant but not severe, and you get the X-ray and so on, that or MRI or myelogram that shows a good amount of stenosis, but not a critical stenosis. Does that patient need to go right away to the surgery or not?
No.
No, the right answer is you don't know. That is a question for a spine surgeon. Okay? So, but still, it's in the red zone. So you still get help. You see that there?
Mhm.
This is not the for you to decide what patient is going to need, but to channel it patient to where they get the best care they can get for that situation. And God bless all your hearts. You're not going to decide if patient is going to get a surgery right away or not, because that's not what training is. And it's the same thing asking me, does the patient need heart surgery or not? For God's sake, does the patient need you asked me the other day, remember about the BUN and so on and so forth. So see, I should know all of that, but what was my answer to that?
You said that's the internal medicine's decision.
That is a good question for the internal medicine, not because I don't know how to read BUN and so on, or they put them in I went through med school and so on, but because there are better people who can deal with that than I am. Okay, and they're always going to be now. And they said one of the best blessing of a person is to know your boundaries. Okay, your boundaries is not to decide if patient needs a surgery or not. It's just knowing when to bring somebody who knows. Okay,
I think they did a really good job, at least from my side of PA school, of emphasizing that as well. So I like having this protocol as well. It at least tells us when we can take the autonomy and when we need to start bringing you into that mix as well.
Exactly. So now I'm going to go here where you see actually the graduation that we developed for that. That's what the meaning of the individual lines and so on. We have not validated it. So here we don't really know, but based on expert opinion of more than 10, 12 specialists, this is what we came up with. And at any point, which of you knows Richard Feynman? Whoever knows Richard Feynman, you get a chocolate. Do you know Richard Feynman? No? Okay, so you get a chocolate too. One for Amanda.
Can't eat it anyway, so.
Yeah, so Richard Feynman is probably the most prominent physicist. Everything you work and you deal with, your watch, your eye, this computer works on the basic of understanding of how electrons behave. He brought the so-called quantum electrodynamic to physics, and things that they weren't solvable, he solved them. So now we can build chips based on his understanding that at the time he came without thing, the computer would do the basic things, would fill our entire room here. And now your watch, show it please. That has 100,000 times more power in that thing, because now we know how to build those chips based on the information what he found out has relevance to what we are doing. And one of the things he said in one of his big lectures, he's my hero, personal hero. Okay, he said, how do we find laws of nature? First, we observe, then we come with a guess. And then we put that guess to test to see if that guess answers our question, observation. No matter how beautiful your theory is, your guess is, theory,
Hypothesis
is. If the observation doesn't support that, you have to throw it away and start all over. So, and this is what we are doing. This is an educated guess, and we are going to gather our data. And you guys all know by now how emotional I am about my data and so on, because that is the difference of being able to build this or not build that. Do we want to be the people who can build that in the future? Then that is the path to be successful, to gather the data, analyze them, and refine our hypothesis and so on and so forth. So let's go back though. This is beyond our conversation today, but so these zones have meanings, okay? And which we have to refine. We have a job to do. But let's go down. So this far you understand, and that's really made it easy. This is really not a complex. You can be LPN and understand this. Patient come with acute progressive weakness, and that progressive weakness is weakness or incontinent. Done. You order pictures and then get help. Now, anything beyond that, the patient falls. If it is not the red up here, patient falls beyond zone red. Meaning you have time. You can go read about it. You can go make yourself knowledgeable, talk to your colleague, and so on and so forth. But then patient falls in the consult zones or green zone. What do you understand when you just look at that? What do you understand on the green, those colors? Describe me what, because we try to do it really that it makes sense just by looking at that. Even you have heard nothing about this. Interpret me the colors.
So I can see, on the furthest away from the surgery zone is the more dark green color. And it tends to be the less acute symptoms that people have and the less acute findings and diagnostic tests that they need. So that's when they go for more conservative therapy. They don't have any of the red flags.
Red flags, I like that. And red.
Yep.
So they are not red, they're green.
No red flags, and they're stable, or if they have some progressive weakness, it's over years and years and years instead of matter
And
of days,
if you want to know
months.
detail, you just go to the next thing.
Yep.
And it tells you what they are. Okay. Well, eventually that'll just sit in you. Like when I was in my first 4 years of the residency for neurosurgery, which is heavy, GCS, I still had the card. Okay. And because in a situation like, it's crucial, you don't want to guess and think, okay, I know 7 times 7 is what?
49.
But in a moment, for God's sake, take your calculator and calculate it. So there is no guessing. You take one step away. That is what the algorithm is, to make difficult thing that you don't miss on simple steps. Okay, this is what the algorithm is. So you go and look at that and say, stenosis, the session, and so on and so forth, and what they really means, those things, symptoms. You see that there? Here is only yes or no. Easy. And then, but you go to chronic weakness and you see what they mean. Okay.
A lot of this that you've been talking about, we kind of discussed in our last podcast about it's just eliminating the bias of it altogether. Is, you can't sit there and be like, oh, well, maybe this and that. You look at them and do they, like you had said, yes or no?
Well, in this town, there are still surgeons that schedule the patient for surgery. When they come to us, they go through our process. They won't even qualify for surgery. They're scheduled to get the surgery next week because we eliminate the surgeon biases. Because you know what? Today morning, I saw 20 patients and none of them was good for surgery. I'm not going to have surgery next week. Oh, you need a surgery. So, and this is, you laugh about that, but this human biases, serious stuff. Thank you. Good job, Amanda. Now, did you know that they did a study? If a judge sees a judge who is supposed to pass a sentence, justice is blind, right? If the sentence is passed before the lunch, it's more likely that they get heavier sentence than if it's after the lunch. Did you know that?
Hanger is real, I guess.
If they had if they acquitted 4 people before, it's more likely they will not acquit the 5th person for same thing. And if they sentence 5 people before, it's more likely to get acquitted. In fact, so these human biases are basic and they're real, meaning that if I saw 5 patients that they didn't need surgery, I'm more likely to schedule the 5th one. So here comes the algorithm, steps, the checklist that doesn't matter how much I want the surgery. Does the patient need the surgery? So did the patient get physical therapy for this and that? Did the patient have one of those symptoms that requires surgery? Does the patient fits in the red zone or not? So this is knowing our biases is the best way to provide go above and beyond your biases and eliminate them. Okay.
I say, as you've named, knowing our biases and knowing our boundaries have been kind of the top 2 things for this algorithm.
So, okay, the color coding is clear now. Kate, look at that color coding and tell me what's your understanding of that consult zone? What does it try to tell you? Obviously, we talked about that the zone 0 patient goes to surgery, done.
Mm.
And green look like that, is not in the consult zone. It seems that, do whatever you like to do. It's your choice. Okay? If the
So-
patient falls there, and we can go back. But what's your understanding of that consult zone?
In the consult zone, depending upon what their symptoms are, kind of determines how fast they would need to see you or what our course of management
Very
is.
close, very close. But it's mostly about you. Now, if you have been in 5 years, when you have a lot of experience, you can go all the way for what I care to zone 1. Not this year, though. This year, you see patient in zone 3, you call me. Okay, but once in a year or two, it's specifically about your abilities, your comfort level with understanding, interpreting, and finding those red flags and so on. So in that, for now, zone 3 is a consult zone for you, but in a year, hopefully zone 2 is a consult zone, not zone 3. Keep the zone 3 for yourself. And one day you will pick up the phone, say, Abbasi, take this patient to surgery. Or you pick up the phone and say, Abbasi, then you're in zone 1. You say, I saw the patient, I examined the patient, then you'll be very specific. You say patient has a grade 2 ischemic L4-5 spondylolisthesis with it's not mobile. Patient has deficits, but the patient has a ejection fraction of under 35. So may need a surgery, but I'm going to send you the patient in 1 month after we have done a full evaluation with a myelogram and a cardiac consult and so on and so forth. You can go all the way to zone 1. You feel comfortable, you understand all the implication of that. But that's what the coloring of the zone, consult zone is, how comfortable are you with the knowledge and so on. If in doubt,
Consult.
Okay, so that's very easy and takes a lot of stress off you. But again, I'm a private pilot, not as good a pilot as a surgeon, but I crashed my airplane. It's a big deal. I was all over the news. But every time something wasn't right, I didn't follow those checklists, which is an algorithm. There's a checklist before you go around the airplane, you check everything. Then you sit in the airplane, you check the systems, and you put a check and so on and so forth. Every time something wasn't right, I relied on my memory rather than on that checklist, say check, check, check. And that's why we developed that checklist for our rounding and so on and so forth. Now, that's just to take the human fallacy out of the equation. Same here. Now, Alyssa, this is a harder question is for you now.
Okay.
Let's say we moved away, patient is not in the red zone.
Okay.
But patient does have weakness that is now for 4 months.
Okay.
Patient has weakness for 4 months. And the weakness is 4+, let's say in tibialis anterior. And how do you progress if you come from, now look at that sphere and see how far they are from red zone physically, like geometrically. So patient comes with the 4 of 5 tibialis anterior weakness for 4 months. What's your next step?
Well, my next step would be, other than doing a straight physical exam, it would next probably moving into the test to see how the imaging lines up with what they're saying.
No, you do the rest of the exam.
Okay, yeah.
Yeah, you
So
do the rest exam.
the physical exam.
Good. So, well, you see, reflexes, claudication, pain, sensory. But there is a reason sensory is on the bottom, and the claudication and weakness is higher up. You see, they're more separated from the red zone, and they're weighted as well as such. But once you get a good understanding, you say this patient is a zone 3.
Mm-hmm.
Okay, you still feel comfortable doing
Okay.
that. So what's the next step? Patients in zone 3. Go.
I consider the consultation as I would with a patient. So then you move into the tests.
No, well, you get the test and then consult.
Okay.
Right.
Okay. I got the
If
test.
they're not, if they're in the red zone, you consult me and then you get the test.
Okay.
But if they're not in the red zone, you get the tests and then consult me
Sure.
with the results. And the difference is that the red zone, I may just jump through hoops and, pick up the phone and make that exam possible, just like next half an hour, or send the patient to the ER. But if you're not in the red zone, you help me out to streamline patient care by getting the test. And that is what I see a lot, that is a mistake, that you consult me without really having those things that makes the decision. So what am I going to do? I'm just going to go and order them.
Mhm,
And now we wasted another 2 weeks of patient's time.
mhm.
Okay, so in the red zone, you consult me, then you get the exam or the tests.
Sure.
In the other zone, you get the tests. You don't even have to wait for the reading of it, but you get the CAT scan or myelogram, and we come back to that. And then with the results, once they're available, not that reading, we do our own reading, but with the test, you send the patient to me.
Sure.
Okay. Now, okay, well, zone 3, weakness that I'm going for 4 months, sensory deficit, pain is 10 of 10.
Usually is.
Help me, patient pushes you. Okay, but that is sort of takes that biases, because one of the things is that when people push us, then we do things differently. Okay.
Yep, we get
Not
that anxiety
always
pressure to do things that we
exactly.
wouldn't typically make decisions.
Yeah. Have you been in a situation like that?
Oh, yeah.
Oh, yeah?
Yeah.
Tell me an example.
I mean, so right when you were saying the patient was saying, help me, and in 10 out of 10 pain, it reminds me of when I was in the ER, and there was a lady who came in and she had a really convincing story, and we were all like believing her. And she had a long history of like actual real medical conditions and everything like that. And I was, I went and presented the patient to my preceptor, and my preceptor was like, okay, sounds good. Like, I'll go and talk to her. And he talked to her and he walked out and he checked the PMP, and
The PMP.
The prescription monitoring program. And she had
And
just,
there's a list of like 5 pages there.
yeah, and she had just like 4 days ago or 5 days ago got prescribed a massive amount of opiates. And then as soon as he basically said he would give her other medications that weren't opiates, she started
Crashing around.
freaking out, getting really mad and angry, and her demeanor completely changed. And that's the thing that came to my mind first when you said that.
Well, do you have some similar story, Kate?
Yeah, I mean, I was thinking like that, but we also did an OSCE in school where we had
What's
like
that, OSCE?
Yeah,
Mhm.
so we have actors come in and then we're evaluated by an instructor in the room, and we have to deal with the patient. The patient is acting similar to that,
Okay.
and we kind of have to talk them down and figure out if they actually need the medication. or not.
Yeah. No, I'm sure you have had similar.
Oh, yeah.
I'm going to tell you another story that really solidifies why you go through the same steps. Algorithm take both things out of equation. I was a 4th-year resident in my neurosurgery residency, and I'm responsible for all the prisoners of the Texas Correctional TCU, Texas Correctional Facility Hospital. When they come, I'm the person. It's 2, and this prisoner, they would be rather anywhere but in the prison.
Mhm.
Okay. Going to a hospital, the Texas hospital, even though it's still a prison, and it's a big deal. You go to a big walk, gates, and so on. For them, is a hotel.
Mhm.
Okay.
I have
So-
a similar situation.
Yeah.
I know where you're going.
So I'm going to, but this 35-year-old lady comes and, cannot move the legs. And every sign on the book that there are exams beyond this conversation tells everybody she's faking it. Okay. And, that there are some tests that you can do, how much effort to put. And sometimes they sabotage themselves by faking more than what it is. They're sabotaging themselves. Okay. So I go do the exam and so on and so forth. And everybody just waiting for me to say, send it back. I mean, she's just damn thing, taking our time at 2 a.m. and so on and so forth. And but I go through my algorithm. My algorithm says, check bulbocavernosus reflex. You want to explain what that is?
Can I say that one more time?
Bulbocavernosus reflex.
Nope. I'll tell you.
Who knows what that is?
That does not involve
Those caverns.
a rectal exam.
It requires a rectal exam, but it's more than that. It is a reflex that is hard to.
Or reflex, that's what you were saying.
Bulbocavernosus reflex. Kate? Bellering? Okay. In a man, you do rectal exam and push on the glans penis, and you feel a
Oh, that's right.
squeeze.
And you do
In the
that,
woman, what do you do with woman?
you do that with the clitoris.
You push on the clitoris, or if you have a Foley, you pull the Foley. So it's 2 a.m. and hell, I'm not going to do a bulbocavernosus reflex on a woman without a chaperone,
Mhm.
right? Prisoner and so on, all the thing and so on. So I'm asking, and nobody wants to come and, oh, everybody's busy and so on. I said, put a Foley in and do that for me. And so after fighting, the people fight you for things, okay? So sometimes you have to fight for the right thing. And I'm tired. I have worked already 30 hours. I haven't sat down. I'm about to fall asleep by walking. But you go through your algorithm. You don't cut the corners. They put a Foley in, chaperone is there. I do the rectal exam and I pull on that thing, nothing. So what's the next step? Get an MRI. I don't care that you have to drive in at 2:30 a.m. Is the protocol, is the algorithm, is exactly for this situation. It's to make a complex situation that your personal feeling is irrelevant, that you didn't sleep is irrelevant. What does the algorithm says? So we got a MRI of the lumbar spine and thoracic spine, the biggest tumor in the lumbar-thoracic junction that you can find. And that patient just another day would have been paralyzed for life. Now, does it matter that she's a prisoner?
No.
No. Does it matter that I haven't slept 30 hours? No. Does it matter that the nurses rather chat with each other than go and put a Foley? No. That is what the algorithm is supposed to do. So you had one situation and I had another situation that the algorithm will eliminate both biases. And that is what it is, to take your peripheral, non-essential thing out of the equation. So,
and we've been told, multiple times not to be biased with our patients, but we've all been in situations where we see through it. And that's exactly what this is.
Yeah,
or we think
we
exactly.
see
We think we see
Okay.
through it.
Okay,
Yep, exactly.
follow the algorithm and you will be fine. That is how you get to the same solution in mathematics as well, by following the steps. So this patient we just talked about, 4 of 5, 4 months pain, 10 of 10. You get the pictures
Images.
and then you consult me. You send the patient to me. But what else do you do even before to send the patient to me? The patient is not in the red zone, or you feel comfortable the patient is in zone 3.
Start conservative management.
Yes, start the
Start
conservative
physical
management.
therapies.
Don't wait until patient sees me. Don't wait that something magically happens. Start the conservative management already in the consult zone if it's not the zone red. In the zone red, get the pictures or consult me, get the pictures. Okay? Anything beyond zone red, get the picture, wait for the results, and start the conservative management. What are those conservative managements?
Physical therapy, bracing,
Obvious, you're like him, okay? Physical therapy,
bracing.
if depending on the situation, if it's a secondary reaction, bracing doesn't help, but for most of the other stuff, bracing does help. What else? Yeah, conservative management. Go ahead, continue. So physical therapy, bracing,
NSAIDs, Tylenol,
pain management,
relaxer,
muscle relax is very good.
Ice, heat, anything that relieves.
Anything that can help them. What about
you said bracing.
I mean, often hydroxyzine or Visceral can be very helpful. Atrax. What kind of medication is that?
Hydroxyzine, like anti-anxiety.
Anxiety. We all need that right now.
All
right?
the time.
So, but why does anxiety medication help? Let's go back to you. Why does anxiety help you in a situation like that?
The patient's having anxiety, a 3 out of 10 pain could be double that or higher.
And there is a physiological thing to that, when your stress level is up, like when you're anxious, you're jittery, you're just jumping around, your nerves are ready to shoot signals when they shouldn't be. So it is not just about anxiety, it's about that truly a pain of 3 would be 7 if you're anxious or if you're just excited and just jittery around that. So always can help and help to reduce the amount of the other pain medication you need to get. For that reason, what do we do in the hospital when we have surgery, which is a stress to patient? We give them.
Yeah, we have a slew of medications, but one of them is hydroxyzine.
And do we give it PRN or schedule? Because, you know, that is one of the things that the nurses, oh, you're not anxious, so I'm not going to give it to you. We want to take that bias out. We are not giving to them because they're anxious. Most of the time they are anxious, but we are giving to them because we know in combination with other medication that they work just better. Okay, so we do all of that. What about injections?
Sure.
Yeah,
We do-
depending on the pathology, you can do epidural steroid injections if it's diagnostically, but sometimes they can be therapeutic SI joint injections as well.
Yeah.
Usually we use them just diagnostically. You can do I can't think of it right now.
Once your knowledge is at zone 1 and
What's
2, order injections.
Okay.
Until then, just get the consult, let us do that. Because that is a knowledge, again, you remember those consult zone is based on your understanding. Once you breathe this, I don't care if you go and order all those injections and so on. And it's bad in Minnesota. In some states, you could even do the injections. Okay. And I tell everybody, I'm a neurosurgeon. Now I don't do that anymore, but I did a lot of intracranial. I did aneurysm and so on. Believe me, I feel I was pretty good at that. But how I learned opening the skull for aneurysm, I learned it from a PA. In Methodist Hospital, that PA has been doing it for 30 years. He had the best opening technique for all my attending. He would open the skull, open the skull, the flap and everything, and then call the attending to come and I learned that from him. Okay? So I learned something from your profession, and I was really good at that. And like, this is a true fact. After that, I was in a different hospital, and we had the similar surgeries. And I started doing opening for the attending. The attending just stood back and watched me. And at the end of it, after I opened that, said, you know, I wish everybody could open the skull like this. He was in shock and awe. I'm like a 6th year or 5th year resident. I opened the skull in literally 5 minutes for him. And I learned that from a PA. Okay. So unfortunately, there are lots more rules and regulation, but we have to figure out, you know, what you feel comfortable and so on, and what regulations allow us. But my take on that is, you know, I have met a lots of people in your group of profession that are better than many doctors. Okay, so, but what I'm getting at, once we build your knowledge base, you order those injections. Okay, but for now, let's just stay in the zone 3. So let's say we do all of that, and here you are. Okay, we have this different kind of thing that you see as well. There is a reason this up here are red, and then closer to red zone, and all these other things down here. Now let's go through that. Discogram. Why is discogram below all of that?
It's less, well, I know that MRI and myelogram and CT would be more sensitive and specific for finding things. Discogram is specifically just for disc
Provocation.
diseases. Yeah.
You provoke the disc. If you have to provoke it to behave the wrong way, obviously it's not as important as if there's a huge chunk of thing in the spinal canal. So it is good information, but it's below the other ones. You see that there? Let's talk about functional tests, the ODI and so on and so forth. Why are they even there?
Well, those are the more subjective. That's from the patient's perspective of how they feel about certain things.
That is important.
It is important,
but not like a chunk of meat in the spinal
Mhm.
canal pushing on the spinal cord. but they are important. Why, what is the importance of them?
Well,
Go
the
ahead.
same thing that we had just kind of brushed on with the anxiety side of things is that it's not so much about what we think, it's how the patient thinks and how they feel. So it doesn't matter what we think or feel.
Let me tell you what the ODI is actually supposed to do for you, okay? What is ODI?
Oswestry Disability Index.
Index. Oswestry is actually a place. Did you know that in
Didn't
England?
know that.
Yeah, it's a place. Starts with
I thought it was some guy.
That's a good guess.
I thought there's some guy named Oswestry.
Yeah, Oswestry, yeah. Now, the idea is that most of the time patients come and talk to you about pain, right?
Mhm.
And pain is always 12, okay? What other things are you can ask the patient that consolidate the actual situation? Like, can you walk? Can you eat? Can you dress yourself? Can you do and that? So indirect things that they may not associate directly, but
Mhm.
gives you a good understanding of overall disability level of the patient. So Oswestry Disability Index. There are how many questions there? 5.
Is it
Then-
only 5?
I think so.
I thought it was more.
There are modification of that, but the original is 5. And then you double the number, and then you get no, I think
It might be 10.
it might be 10. Yeah, I think that the newest version is 10, and then you get 1 to 5 and double it, then you get the numbers from 100 to whatever
okay.
it is. Okay, so
Yep.
but at the end of the day, you try to get to the pain indirectly or disability indirectly, not just by the pain, because pain is always 12.
Mhm.
Okay.
Mhm.
And the change of that is a good thing, you know. If that was like 60 before and now is 80, it's more important than it's just 60 or 80. Okay, the change of that is important.
Mm.
Now, psychosocial status. Obviously, it is important.
Yeah.
Okay, it is not. When we say somebody has psychosocial status, it doesn't mean that we are dismissing their thing, but we just acknowledging that that's part of our protocols.
I have a funny story about
Yeah,
that.
go. I want to hear the funny story.
There was I did a rotation in a hospital, and there was a psychiatrist that all the hospitalists didn't like him because he would be taking care of a patient that had schizophrenia or another severe mental condition. And he'd say, "Oh, my arm's on fire. It's literally on fire, and there's bugs crawling out of it," or something like that. And he'd put in a consult for hospitalists to come see him, even though clearly the man's hand was okay. So he would consult them for every little thing. People would say random things, any random thing, and he'd say head pain or eye pain or something like that.
But did you know that can be a dangerous situation that you get a consultation, you know all our tests. You have certain level positive, certain level negative, and then you have a positive predictive value and so on and so forth. Meaning that if you start doing 50 tests, it's almost certain that one of them is positive just by chance. And then you start acting on that test, and that put the patient at lots of risk without really any benefit. So this is knowing that is important to understand that that is part of our protocol. Okay, that the 10 of 10 pain on somebody who just the husband died, and this is sometimes that as easy as that. Husband died, the dog is getting put down, and they lost the home, lost the job, and pain is 15 of 10. That we are not dismissing all of that, but we put it in a different weighting on that, and then don't jump to surgery because of that. Okay, so these are important factors. And obviously, why is Karnofsky important here? Why did we put in our group Karnofsky there? What is Karnofsky index?
I don't know.
Karnofsky is meaning how you are. Like if your Karnofsky index is really low, meaning you're about to die. Your Karnofsky index 100. Very vital, very everything, and probably
That's what I do.
85, and somebody's maybe on 20 now. If somebody is so sick, we are more cautious to give them surgery because and it's about the patient. It's not about my glory that if I do that, patient have complication and will die of my surgery. No, I have a bad result. It's about, can I really help the patient? If patient is vital, attend that patient more. If patient is about to die and now I put more stress with the surgery on them, so it's less. So if you go down here, you see that the Karnofsky index here, that depending on where they are, they qualify them. If it's less than 40, conservative management, no surgery. Okay, so these are all factors that help us to understand how we can help the patient best. And then if you follow the protocol, the algorithm, all three of you will perform the same. It won't get that just because you had a good day or you had a bad day doesn't mean that patient get a different day by doing that. Now, let's come below and all of that, all the green goes to I put PM&R, but this actually means just conservative management, okay? Now, diagnostician, let's go talk about the bottom half of that thing. You want to just read it and tell me what you understand, just based on what you see there, what you understand there.
Based on the diagnosis? Is that what you're saying?
Well, let's interpret for me the bottom half of that sphere,
Okay.
and that's truly a sphere, not a circle, because it's multidimensional. It is like, imagine it, like you have a sphere and then rain falls on top and you have different weighting of those graduation. And then if something has more weighted, it's like water flows faster to the middle, take the patient to the surgery. When you're outside, it's more flat. Takes longer. You need to have more time, take longer for bad thing to happen. Okay, so bottom half of that sphere.
Okay, so basically how I interpret this is, so you have the right side that is kind of going from less severe to more severe as it goes towards the red, the surgery zone. And then on the left side, it's doing the opposite, where it's going from left in towards the red zone. It goes from least to more aggressive therapy managements. So then, you start with the top, which is I can't even read that.
Adjuvant therapy.
Yeah. And then you go down, obviously.
Adjuvant therapy, sometimes just talk.
Oh, sorry. I was on the left side. My fault.
Okay.
Yeah. But basically you can see that would be leading you more towards that green 3 area. As you get down lower, we can see that someone with instability.
What that means? That
sure. Yeah, I would love to. Depression and
conversion disease.
Okay.
And, psychosocial kind of problems. Okay.
Sure. Okay. Yeah.
And in the next slide, you will see what they are and what they mean. Okay, go ahead.
And that basically you can see then as you get more towards the end, you get, tumor herniations, infections. You can see that those are those red options that we need to think surgery right away or sooner than possible, sooner than later. And then again, as you can see on the right or the lower left side, you start towards green, which is the acupuncture, the PT, the conservative therapies that we typically all patients get. And then you move down as you get to the surgery zone and you get to more of the surgeries, the decompressions, the fusions, the discectomies, etc.
Very good. So it's almost, if you just look at it with open mind, it's explained itself. So Kate, what does that distance of those things on the sphere, the distance on the sphere to the zone 0, what does that tell you?
What's the least, I guess, or the most conservative versus the most invasive approach, I guess, to their management?
No, actually it tells you how fast or how aggressive you should be to send the patient to me. Okay, somebody with a diagnosis of chronic pain is further away from the surgical consultation than somebody who has a myelopathy. That's what that distance means. And so, and for that, sometimes you just can't read the radiology reports. It's radiographical myelopathy. Myelopathy has 2 forms, right? You want to tell us what those 2 forms are?
So there's the functional, or what you find on the physical exam, and then there's the radiographic, which shows
clinical myelopathy versus radiographical myelopathy. Alyssa, what is the clinical myelopathy?
That would be when you were doing a physical exam and you are witnessing those symptoms based on.
What are those symptoms?
Yeah, ask the ones that do that right now.
Bonus, positive Hoffman's,
Babinski
Hyperreflex.
pathologic reflexes, the group of reflexes called pathologic reflexes, including Babinski and Hoffman and so on. What else?
For the reflexes or what other signs?
Other signs of clinical
Hyperreflexia.
hyperreflexia. Yes. What else? What did I do with that patient that we had a question of myelopathy? What is the first thing I did when I entered the room? Remember that?
Strength. Or
No, I did something. I said that, can you walk for me?
I said
Oh,
that.
yeah.
That was,
The
yeah,
gate. Check the
good.
gate.
Take the gate. Yeah. Why is it? No, you said the gate.
I know me. Check up for
So
anything.
No, but that is myelopathy specific. Why at the gate? Why did I went there and the first thing I did say, can you please walk for me? Why? Do you remember the cross section of the spinal cord?
Yeah.
Look like a butterfly. Okay, not butterfly.
Not
here? No.
today.
Oh, it's a butterfly. The spinal cord looks like that.
Yeah.
If this is the front, this is the back, and on the back of the butterfly, there are those so-called the posterior column.
Mm-hmm. Okay.
They are what? They are least myelinated fibers. And if the pressure on the spine, they are the first to go out. They have the least protection.
Okay. So
What
you
are
can
those
tell a lot
fibers?
based on your guts.
Yes, I'm giving too many chocolates out today. So what are the posterior column fibers? What do they convey?
signals from the brain down the spinal cord, and then they synapse with the lower.
It's actually from below up.
Okay.
Okay. What are they? Gracilis and cuneatus. You remember that from anatomy?
Yeah.
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 I knew that
Remember
one. I knew that one.
See the bottom one, gracilis and cuneatus. They get all the sensory from our every place in our body they take it to the brain. Well, sensory, big deal. But what is it important else there? The proprioception.
Mm.
Okay. So what is proprioception?
Yeah, awareness.
Like where your body
How
is.
does it work?
Balance. You have so basically, I guess my idea, they always said, like, if you close your eyes and you put your hand up or you moved you anywhere, you would know where you were at
Okay,
due to proprioception.
Do this. Close your eyes.
Okay.
All three of you. Close your eyes and open your arms and don't hit each other while you're doing that, and touch your index finger together. You did all of that perfectly without really looking at it, because you knew the position of each of your joint. And this is big deal. I cannot tell you how big of a deal it is to do just this, okay? And that is when you're drunk, you cannot do that and so on. Or touch your nose.
Yeah.
Touch my finger. Look at
Cerebellar. Cerebellar testings.
Am
Ooh.
I supposed to be looking at you?
Yeah, okay, so you see it there?
Yeah.
Or look this.
Oh, yeah, the opposition.
Unbutton your shirt and so on, because most of the time you don't see it and so on. Now, proprioception, the position in the tendon, in muscle tendon, and the joint and so on, we have receptors that tell me my joint is, actually there's a really nice thing there. Close your eyes one more time.
Okay.
And close it. And put your right arm in a very funny position. Yeah, good. Yeah, good. Now, you have a mental representation of what you did in your brain. You know exactly what you did. You can open your eyes. Look at him. No, you see that?
Like cramping.
But did you have a mental representation of in what position your arm was in your brain?
I knew exactly what I looked like on that screen
So
for
you
everybody else.
So you exactly knew what position you are. And that is based on your proprioception. That is based on the posterior column. And based on the cuneatus and gracilis that tell your cerebellum and your brain what position you are. Because they are very sensitive, if there's a pressure on the spinal cord, they are the first thing to go out. That is why proprioception, ataxic gait, and so on and so forth is a sign of myelopathy. Does that make sense to you now?
Yeah.
Okay, so look for it. If you see that, red zone and
Surgery,
well, the consult right away. Okay. Now, that myelopathy is not obvious. Why is, if myelopathy is so important, why is it on the.
Why
up
is
there
it
in-
not a red?
Because we don't know, we have to get those things before we can determine if it's.
Myelopathy.
Yes, yes, it is not, patient doesn't come to you, oh, I love it, and so on, okay?
If only it was that
So
easy.
that is why it's not up there, but they say, I can't walk in the last few weeks and I'm getting weak, I'm peeing myself.
Mhm.
Those, you see, that is the reason it is there, but it's not up there,
Mhm.
okay? So, and then obviously on the management side, from least extensive and invasive to most invasive and extensive part. Our goal is that independent on who patient sees, they get the same care based on their need and not your abilities. Now, and again, if anybody who's watching this, you have a question, let us know. We send you these cards and the interpretation of that and a
Mhm.
copy of this thing. This is the accumulative work of lots of very highly educated professionals, okay? But at the end of the day, it's still a work in progress
Mhm.
and practically educated, yes, if you want. It works though. So try to implement it in your cancer. So if we have take 5 things out of this meeting today, I want you to go around and each of you tell me 2 of the things, one at a time. Then so because the other ones have the same. So tell me the first thing you get out of this meeting today, Alyssa.
For me, I guess the most important was knowing the difference between getting the imaging before the consult anywhere from 1 to 3 versus if it's surgeries, don't get that or consult you, then get the imaging. So
Okay,
for
next for you. What do you get out of this meeting today?
What the red flags are and how to notice them.
And the red flags are right there.
Right there.
she goes,
Right there.
don't look.
Yeah, no, yeah. So
For me, it's the origin of the word algebra.
good one.
No, I'm just kidding.
No, really.
It's always good to repeat.
Learn,
this.
learn, learn.
Could you repeat it back to him? Because there's a lot of steps.
But I think for me, I always like to go over the red flag symptoms. I feel
But
like
she used the red flag. You have to use something else.
okay. Well, the next steps after red flags and when to say something is and isn't a red flags. I think that's the most important.
So yeah, we are going to go one more round.
That's fine. I guess these are things that aren't always new, but it's new realizations. And seeing this almost as a guiding tool along with your education. We talk all the time about we're treating the patients. Right. Yeah. We're treating the patients, even though they may have some of those things, follow it as instructed and it'll work out.
So now quickly, do each of you one, because I have a meeting right now I have to attend.
Removing
Another.
your bias.
And the hierarchy of physical exams symptoms where you have chronic weakness at the top and sensory deficit at the bottom.
Very good. And what I take out of this is that, that I learn it every day. Even people with psychosocial problem can have organic disease that you cannot dismiss. I learn that every day. Now, it is a crude way of putting that and never repeat that, but the way you don't forget about this, even crazy people can have organic disease, okay? So never dismiss that. So it has been really good. And we are going to have to conclude this for Essence. This is our Essence of Medicine podcast, the multidimensional protocols.
My name is Alyssa Haber.
I'm Kate.
I'm Mike.
And I'm Dr. Abbasi. Thank you for joining us.
Thanks, guys.
Thank you. Good job. Yes. One of the things I need you guys to do, education is a big part of what we do. Now, just get together with the rest of the team, come up with what we should teach, for example, in that boot camp. Sure. And I want you guys to teach it as well, not only learn, but as well teach it.
I can get in contact.
Yeah. It's not the best thing you learn is when you're teaching things, okay?